epilepsy, and also he's published many articles plus 3 Cochrane reviews, president-elect of Indian Epilepsy Society, and he's also the Education Council member, an expert reviewer. And Dr. Midhirata, welcome to the panel. We are privileged to have you with us. Do we have the next? So this is the time when we request our inaugural speech by the backbone of so many things. The less said, it'll always be less. It'll always be said. Welcome, Dr. Surya. You're an inspiration to every one of us, and you're the catalyst. So he needs no introduction, but for those who are new on the webinar and not familiar, he's associated with the Bombay Hospital and Medical Research Center, Saifi Hospital, Northcote Police Hospital in Mumbai, very, very active. He's chairman of the Surya Neuro Center, founder trustee and chairman of the Epilepsy Foundation, founder president IFNR to 2012 onwards, president-elect for IN 2021, treasurer, Neuroscience Academy of Telecare and Artificial Intelligence, which we really need at the moment. And I'm sure it's going to go far ahead galloping. President 10th WCNR. And I have to tell you personally, it was a fantastic experience. And so was it the second time. He is the regional vice president WFNR since 2006. President-elect Asia Oceanic Society for Neuro Rehab that just concluded with another phenomenal feather in the cap. Executive member for Indian Stroke Association, member at large, president at WFNR, chair Developing World Forum. So, Dr. Surya, welcome, and a hearty welcome also to you, and maybe have your inaugural speech, please.
Thank you very much, Vidya. At the offset, I want to thank Professor Midhirata for chairing. He is the chairman of Neuro Rehab subsection of Indian Academy of Neurology and very dear colleague. So welcome. Thank you, Sonal, for getting me into this webinar today at a very, very short notice. And I know that today is a very, very important day. And for those who जिनको मालूम नहीं है या जिन्होंने ये पता नहीं किया कि आज ये क्यों हमने वेबिनार रखा है, उनको मैं बता दूं कि यूनाइटेड नेशन में, जिसको हम यूनिडॉप के नाम से बोलते हैं, कि यूनाइटेड नेशन इंटरनेशनल डे ऑफ ओल्डर पर्सन, और ये 1st October, that is 1st October, it is being celebrated. It was December 14, 1990 that UN Assembly voted that 1st October should be the International Day for Older People. And the resolution was passed 45th by 106 on December 1st, 1991. On December 14, 1990. It was the 1st October 1991 was observed as holiday for the older people. And it is predominantly to raise awareness about the contribution being made by the elderly people and issue affected by them. As you all know that there are nearly 700 million people over age 80, which will increase to by 2050 to about 2 billion. And why we are talking of MCI, and what is MCI? Minimum cognitive impairment, which is a central stage between a normal aging versus the dementia. So it is exactly in the center. Now in MCI, as you will know more and more, there are esteemed colleagues, Dr. Apurva Puranik, Ashutosh Chavan, Jwala, Udit Combs, Archana, and Sonal, about what are the various facets being affected. But I tell you that every year there is 1 to 3% people develop dementia, of which 10 to 15% patient may have an MCI, and of these 12 to 18% people above age 60 have the MCI. So there can be a many of these patients from MCI, 12 to 15 or 18 or 20% patient can go on to develop the Alzheimer's dementia. You will also hear, I'm sure, about the newer drug, aducanumab, which is a latest entry by FDA. It is being passed very fast, very expensive, which removes the amyloid plaque and reverse the dementia. So you'll probably hear from Apurva about this stuff. I just want to say that what is the theme of 2021 UNIDOC? And very adeptly, the United Nations has given the theme as digital equity for all ages. And very apt because in this COVID, it is the digital communication which has saved the people. So the need for access and meaningful participation in the digital world by the older person is recommended. And I feel that through this webinar today, we must reach out to the people and we should start a classes of digital education for elderly people above 60 years of age, so that they know how to do the WhatsApp, they know how to connect with the people, they know how to attend the Zoom meeting, they could search certain things, and they could communicate or contact somebody in the emergency situation. So that is what is need to be done. As you know, sir, that in developing country, 87% patients are digitalized, connected, and in developing country it is 19%. And of these, our worst is women and elderly people. So therefore, we need to work on a human right, sustainable development, excessive and cyber security and ethics and accountability. So Vidyasi has been very active, and I think the job in her hand, and if she can start the digital classes for elderly above 60 years of age. We can also take these classes to some, the Nana Nani Park or some of the elderly home, so that not they will start using the old phone, they start using the master, the smartphone. So with that note, I wish you all the best. And WFNR is into the 25th year, celebrating the 25th years. And I bring wishes from WFNR also for this meeting. With that note, I thank you very much. And I will be very interested in listening to the esteemed panel for next 1 hour. Thank you.
Thank you, Dr. Surya. Wonderful advice. Digital technology must go into homes for elders. And I'd be very pleased to tell you that we have just released, with your blessings also, the the app for elderly. It's a music app that is called Memory Karaoke, and I will put it on the group, the links. And we've got a very good response, and Dr. Surya has always been there. And we've had wonderful, people giving us, in fact, Alzheimer's Disease International has commended on it. This project came about 3 years ago. It was on hold because of finance as usual. They came back in June, July, and we worked on it, and MTV financed it and sponsored it. So it's gone viral. So I'm very pleased, and we will take your advice and go on to the elders for digital education. Thank you.
Many congratulations. Many
Thank
congratulations.
You. Thank you. And WCNR wishes also. Thank you again. Maybe have Professor Midhirata, please, to take over as chair.
Actually, I am outdoor, and actually I'm in Amer Fort. There is a big group here, so there's a lot of noise, so I didn't switch on my mic. Okay. I wish to send my congratulatory message for this wonderful action. what is my role, not only as the chair of this subsection of IEN, but I have brought out an issue on mild cognitive impairment around 12 years back of Indian Academy of Neurology. Then I am also the director of VASCOG Asia, and we are just coming out with a book by Cambridge Press. And that book, I also have contributed to therapeutic aspects of mild cognitive impairment. So though Sonal has asked me to read a question for the panel, but I think I'll request Dr. Apurva Puranik to carry on because there are a lot of people around and a lot of noise around. I don't want to have any disturbance in the wonderful program, and my best wishes, and I'm always available for any service which I can do. Being a senior citizen myself now, I know the importance of these things. And when patient comes to us, ignored by the family, late coming in India, and vascular cognitive impairment taking over the mild cognitive impairment of Alzheimer's disease. So from that angle, I am very, very sensitive. And definitely in India, we need better awareness, better education to people come to hospital or family brings to the hospital early so that it doesn't become late. Wherever we can do intervention, whether on the diagnostic front, which is nicely available now, CSF amyloid protein, as well as therapeutic armamentarium. So with this, I will say very best wishes to the panelists. And I will request Dr. Apurva Puranik to carry on rest of my duty also. And very best wishes for inviting me. Thank you so much. Grateful. Yeah.
Thank you, so Professor Dr. Midhirata, for even coming for those few minutes and gracing the panel discussion. So thanks a lot, and we look forward to reading the book and have a wonderful event where you are. Thanks a lot.
I will be around. I will be around. I'll mute myself and keep video off. Thank you so much.
Thank you.
Thank you. May I have a chair introduce speakers?
Yeah, I think, Sonal, I think if you put on the slides, we can introduce a panelist. Yeah?
Yeah, yes.
Yeah, okay. So we have Dr. Apurva Puranik. Yeah, I can see it. Thank you.
Please, ma'am.
Yeah. Welcome, Dr. Apurva Puranik. Just to introduce him, and all our panelists have been, chun ke liye hain. So there's everybody who knows that person. However, through the ritual, Dr. Puranik is director of the Puranik Academy of Medical Education, ex-professor neurology, MGM College, Medical College Indore, co-chair WFNR, SIG Communication Disorders. Also, his hallmarks and star achievements are Park Davies Award for Epilepsy Services in '94, International League Against Epilepsy Grant for Epilepsy Education in 1994 to 96, Rotary International Grant for Epilepsy 95, member Public Education Commission International Bureau, visiting teacher Neurolinguistics, Osmania University, Hyderabad, advisor at the Palatucci Advocacy and Leadership Forum, American Academy of Neurology in 2006, recognized as Entrepreneur Neurologist, World Federation of the newsletters, publications 50 plus, presentations 200 plus, fantastic international and international publications, Charak Award of the Indian Medical Association. So here we have Dr. Puranik, and I think he will take the baton from Dr. Midhirata. Please welcome Dr. Puranik.
Good evening, everybody. Am I audible?
Yes, thank you.
So best wishes and congratulations on the International Day of the Aged or Elderly Person. And by the way, I may also share a small important fact that not only the International Day, but the United Nations has also declared the day of the decade of the healthy aging. This is from 2021 to 2030. The decade of healthy aging by United Nations has been recently announced. So we are embarking on a very exciting and ambitious journey to do many activities in this decade, not only in this year. So coming directly to the point, I again congratulate the organizers for coming up with this activity, and I will now start sharing my screen. Is my screen visible? Hello? Is my screen visible?
Yes, it
Yes,
is.
sir.
So, what are the challenges in the diagnosis of mild cognitive impairment? So, all of us know that it is a clinical syndrome similar to dementia or a precursor to dementia. Not in everybody, but in a significant percentage of sufferers from mild cognitive impairment, it can be a precursor. There are no specific instruments or cutoff scores that define the condition, and hence we need extensive or comprehensive neuropsychological tests for informing the clinician on the likelihood that the participants fulfill the criteria for MCI or not. These data can be useful in refining the diagnosis, but ultimately it will remain a clinical diagnosis. So what is our challenge in India? We need popularization and wide availability of screening as well as comprehensive test batteries in Indian languages in digital format, which are standardized and validated and which are easy to use for clinicians. Of course, we need a referral to a neuropsychologist, but the referral to a neuropsychological specialist, there may be restrictions. There may be financial restrictions, there may be traveling and time restrictions, and availability restrictions. So we need some tools which can be used by clinicians, even at a primary level, even at a secondary level. And here I would like to mention, there are some tools which are there, but what I've written is we need to popularize them, and we want to make them widely available, not only for screening, but also as comprehensive test battery in Indian languages, which are standardized and validated. So one pharmaceutical company had tied up last year with Cambridge University, and they were supposed to come up with one such tool. This is a chart from one of the recent paper in American Academy of Neurology.org. What are the transitions from mild cognitive impairment to dementia? So this, the bottom line is, these are the people who are not transitioning to dementia, and there can be early mild cognitive impairment, there can be late cognitive, mild cognitive impairment, and over a period of 5 to 10 years, about 50 to 60 to 70% people will transition. So that is the rate of transition. So of course, from the early MCI, it will take a longer time, and from a late MCI, it will take a relatively shorter time for transition. So that's a very important aspect, that we need to do repeated neuropsychological. So one assessment is not enough. Like a growth chart in an infant and a young child, as they say, the WHO growth charts, one reading is not enough, whatever percentile it may be. It is the follow-up. So for MCI, you need follow-up. From the same paper in Neurology 2021, they have done a cluster analysis in which the group on the left side is optimum cognitive functions. So these are the best people. Then typical cognitive functions, these are the average people. Then they have non-amnestic MCI. The next is amnestic MCI. And the last one is mixed MCI. So the mixed MCI have worse prognosis as when it comes to progression over a period of time. In all domains, in learning and memory, in attention, in executive function, in language, in visuospatial function. So whenever we approach clinical evaluation of MCI, we must try to categorize them, that whether it is non-amnestic MCI, amnestic MCI, or mixed MCI. The same thing is shown in the form of Kaplan-Meier survival curve, that the mixed MCI have a much faster worsening towards the dementia. And again, this was the role of biomarkers. So concentration of CSF beta amyloid and tau ratio with amyloid beta 142. This was again assessed in the cluster group. And as you can see, in the mixed amnestic group, this was the lowest, and the opposite would happen, that the tau was highest. So these are the prognostic indicators and the biomarkers utility. The same authors, they studied the neuropathological findings from Alzheimer's disease pathology severity based on their criteria. And as you can see, in the optimum cognitive functions, there was hardly any AD pathology, but in the mixed MCI, the AD pathology was very high. So these are some of the studies. So it's one recent study, and I conclude my part of presentation here by saying that there is a need for Indian studies on biomarkers, because there can be ethnic variations, and there are racial and genetic variations in different populations. So biomarkers are a hot area. I think they will be helpful in our assessment of mild cognitive impairment also. So with that, I conclude my comments. Thank you very much.
Thank you, Dr. Pauranik. Wonderful presentation, crisp and well explained. So thanks a lot, and we will be coming back for discussions. Thanks once again.
I will have 3 more slides later on during the management part.
Yes, surely. Thank you. So we move on to our next panelist, Dr. Ashutosh Chavan. He is the consultant psychiatrist in Meadowlark Healthcare Hospital, Sayadri Hospital, and his experience is that of 18 years. His achievements and honors have been getting the gold medal, being awarded the gold medal for outgoing psychiatry resident in Manipal, Kasturba Medical College, World Psychiatric Association Young Psychiatrist Fellowship, Dr. K.B. Dhruv Kumar Award from the Karnataka Psychiatry Society, Dr. Amit Bora Memorial Award for the Best Scientific Paper, Dr. Norman Sartorius' AMH Leadership Training Scholarship. And, you know, with such enlightened people with a lot of promise, we look forward to hearing Dr. Ashutosh Chavan. And not to forget to mention that his publications and presentations are 50 plus, great going, and we look forward to your presentation eagerly. Welcome, Dr. Ashutosh Chavan.
Thank you, Shinoy, and thank you for having me over here. Sonal, were you able to get my slides on?
I'm just sharing it. 1 minute. Yeah.
Yeah.
Are the slides visible?
Yes, like at least I can see it.
Yes, visible. Thank you, Sonal.
So, should I start?
Yes.
Yeah. So I think we were listening to Dr. Puranik's presentation. I think this is an interesting concept, and I remember doing my first when I joined as faculty in Manipal. This was the first seminar that I chaired on mild cognitive impairment. This was way back in the year 2004. And I can see as I was reading through this, and the concept itself has gone through a major change. Now I think the reason why I've used this word evolving concept is because I think we still have a long way to go in terms of the way we look at this. We definitely know that this is not normal aging. We very clearly know that this is not dementia. But then it's in between, and in between there are multiple categories. And I remember at that point of time also, when we were preparing for different things, presentations or exams, we would read about benign senescent forgetfulness, age-associated cognitive decline, mild cognitive disorder, and that concept has evolved. So concept came back around 40 years back, but I think it has gained importance over the last 20 years for all the right reasons. Now prevalence of in 60 years and above is 15 to 20%. But the interesting thing to remember over here is MCI to dementia progression is roughly 8 to 15% per year. Now that's a big number, right? But do all MCIs convert to dementia? Probably not. Now that's the reason why we look at this as an entity where, we need to invest time, invest research, and look into various, progression graphs, which I think Dr. Puranik he presented it, during his slide presentation. Now, the interesting part over here is that 35 to 75% of individuals who have MCI have one or more neuropsychiatric symptoms. Now, why is this important for me? Because when, as a psychiatrist or as a person who deals with neuropsychiatry, when I see a person who is 60 plus, who presents with fresh onset neuropsychiatric symptoms, and where I'm not able to add up those symptoms to a syndromal diagnosis as would be seen in ICD-11 or DSM-5, I think we should then various organic or neurodegenerative conditions, and one of them is MCI. There are various subtypes of MCI, as we all know. The concept started with something which was a precursor to Alzheimer's disease, but then over a period of time, this concept started, getting into all dementias. So we have vascular MCI, we have different forms, which I think everyone is aware about. Now, the interesting point over here is that were we looking at something which was pre-dementia, which was on lines of pre-diabetes? Now, the problem is that maybe yes, but the problem here is that we don't have the kind of biomarkers that we would have in conditions like diabetes or more, so say, for example, now during so many years of dementia research, we are still struggling to have, clear biomarkers or, for various other forms of, dementia, which will help us in prevention. So I think if we are looking at it purely from preventive perspective, I think that's where the struggle is. But I think, like I said, the concept is interesting, and I think we should invest more research in India to work on this and see if. So when I talk about research, another problem that stands out is that most of these testings are based on objective evidence. I would ask someone that something is happening. Are you, various questions. There is objective and subjective data. And if we are able to match the data together, we'll be able to get, far more convincing evidence. Sonal, could I have the next slide, please? So one, it goes beyond memory. So earlier the concept was it was only about memory. Now that takes us back to concept of forgetfulness and amnesia. I remember, and now also we follow this concept that if a person is given a cue and they're able to recall, we're looking at forgetfulness and concepts like benign senescent forgetfulness. And this is not something which we would have to, really take beyond the concept of normal aging phenomena. But then these categories have opened up over a period of time. This is what last 15 to 20 years of research has added on, that we are looking at it as something which progresses from this state to amnesia. And that's where MCI becomes relevant. Now, the interesting concept that we are looking at is of benign senescent forgetfulness, MCI. Now, there's a concept called as MBI. This concept came around 2008, 2010, when we were talking about mild behavioral impairment. And they had divided categories into MCI with neuropsychiatric symptoms or MCI without neuropsychiatric symptoms. Those were the first two categories. And then they had two other categories, that was mild behavioral impairment with cognitive deficits or without cognitive deficits. And that's where probably we started looking at more of precursors to frontotemporal dementias or dementias presenting more with behavioral symptoms. So, like I said, the concept of MCI as a, as a compartment might not be the best thing. I'm talking about things maybe which should be more on a continuum, that we are looking at benign senescent forgetfulness, we are looking at MBI, we are looking at MCI, then mild dementia, and then probably everything gets incorporated as pre-dementia. And that's where probably then comes the preventive part of all this. Single domain versus multiple domain, amnesic versus non-amnesic, degenerative versus vascular pathology. I think we are all aware about that part of it. Now, cognitive and neuropsychiatric symptoms, till date, we have debates in terms of whether this is late life depression with cognitive deficits, or this is severe depression with pseudo-dementia, or is this something which is purely dementia that is, that we are looking at, and this is just an early symptom. And we have these symptoms. So there are people who would just be treated as depression and would completely come out of their state. There are people who would continue to have mild deficits, and there are people who would purely be depression, dementia, and with the behavioral symptoms. So this is how the overlap works. My intention was to bring out probably these, conflicting diagnostic entities because that's where we struggle with. The most common symptom that we see in a psychiatric setting and based on the literature as well is depression. 20 to 40% individuals who present with depressive symptoms, and only differentiating feature between a classical depressive syndrome and a person with MCI or dementia and depression is that we will generally not be able to fulfill criteria for depression in these individuals. That means the classical diagnostic entity that we have 3 symptoms here and 5 symptom count, and then you would add up and say that, yes, this is a syndrome of depression. Here, you would see them as more symptoms than syndromes. And that's the reason why at times generally we have in these entities a concept of minor depressive episode, which generally people would talk about. Psychotic symptoms, mainly hallucinations, is what we would see, fleeting delusions, disinhibition, agitation, and agitation onwards, euphoria, irritability are generally something which you would see in any kind of a degenerative process. So these are commonly documented or reported symptoms. DSM-5, something that has come recently, has gone ahead and added on the concept of pre-dementia right now. And that's the reason why I'm saying MCI, pre-dementia. I really feel that all these entities at some point of time will fall on a continuum. Right now, initially when it started, it was more of an entity in itself, but as time progressed, we are seeing everything kind of getting stacked up. So when I say literature flawed with lack of homogeneity, if you read through 10 papers which talk about MCI or these states, we would not find a single homogeneous criteria. Each one would use a different criteria, a different tool, and that's where probably the differences come from. So there are studies which would say, so there is a Mayo study which from Mayo Clinic which talks about almost 80% conversion from MCI to dementia at the end of 10 years. Whereas there are studies which would say 40% of individuals started showing improvement, 20% individuals stayed as MCI, and 40% progressed to dementia. Now, timelines are different, testing tools are different, modalities, studies. So that's where lack of homogeneity probably adds on to a confusion, and probably we are not looking at something which is a watertight compartment, that we believe it is. Next, please. Sonal, could we have the next slide, please? Now, tools and biomarkers. I think we probably, if we are looking at something, especially I think like Dr. Puranik said, we should have something which is Indian studies. And I think for that, we should look at something which can add up as a screening tool, which then we can think of something which would work as a testing tool which will validate probably all this. Biomarkers, we are still probably in early stages, but like I said, so GDS is something which Reesberg spoke about, and MCI criteria of 3 is what they use. MMSE 28 for people who are educated, 26 for people who are uneducated. CDR, we use a criteria of 0.5. Now, all this helps us in kind of figuring out where the person stands. But trust me, we can get these values in a person with pseudo dementia as well. We can get, so screening should be then validated with something which is, so we have this neuropsychiatric inventory questionnaire. And like I said, if it goes up to 80-85%, this is a valid tool. And if I say that MCI is MBI with cognitive deficits, then I need this plus those other tools. So my intention is that to highlight where the difficulties come in when we talk about testing or planning and execution of the treatment plan. Now, neuropsychological testing, I think we have esteemed panelists who would talk about it in detail. This is a very small study we did around 10 years back at Sahyadri, and in fact, one of my co-psychologists, Gauri Chaudhary, she went ahead and published this presented this as a dissertation. So she spoke about, I was talking to her, she said episodic memory test was the best indicator of decline increase in the test study that she did. And she said that during the, and this is what the literature also says, that it's not just patient's report, it is the report that comes from informants, which becomes equally important when we are especially looking at an entity like MCI or any kind of cognitive decline. But here, because patients at times would not know what is, they would report, and there's a mismatch. And then if you work on this, it is informant's report which works better than patient's report. Neuroimaging, we always talk about volume loss in hippocampus and amnesic kind of MCI, or other forms where we are looking at dorsolateral or dorsomedial and caudate, especially these things kind of stand out in people with non-amnesic kind of MCI. Functional and amyloid imaging, Dr. Puranik was already talking about it, so I'll skip that. So controversies in future direction, I think that's what I wanted to bring out, that are we talking about prevention over here, or are we picking up a disease in its early stages? If we are picking up dementia in early stages, then I think prevention would go probably one step ahead, and we should be focusing on identifying those risk factors and preventing those risk factors from happening. And I think that's where the future studies should go. And because I really feel that we're just adding on one more stage before probably mild dementia, where functioning or activities of daily living start getting affected. Then we talk about, we definitely get a window to treat. But if you look at the studies which talk about aging to pre-dementia transition, they would say that probably 10 years before the first sign is seen, the process has already started. So probably that's where we know we should get into. MCI obviously gives us those 5, 6, 7, 10 years extra if we are able to pick it up early, but probably our work should start maybe 5 years before that. Like I was pointing out, stability of diagnosis. 40%, the conversion can be 80% to dementia to 40% improving to 20% staying as mild cognitive impairment. So I think, like I said, homogeneity. Or all categories pre-dementia, maybe not. So we are looking at probably a mix and match, because these entities at times get very loosely defined, especially in research. Ethical issues. If I diagnose someone as MCI, the next question they would ask is, am I going to, suffer from dementia? And if yes, what are the ways to prevent it? And what are the ways to work on it? So yes, there are medication, but how much of evidence at this point of time? Probably donepezil, to some extent, pyribydyl, then the new drugs that we are talking about, but we don't know if an MCI to dementia conversion, how much that would help. Non-pharmacological intervention definitely seems to be showing more evidence right now that people who are taken up for early computer-based or one-on-one cognitive retraining, they probably have at least their quality of life seems to improve over a period of time, and there is some evidence that the cognitive decline would probably slow down. I think we could probably leave from autism management and how early intervention on autism helps. Probably early intervention in pre-dementia or maybe early stages might help. So aim should be to work towards primordial presentation like other illnesses. And I think looking at it as on a continuum rather than looking at it in compartments might be the better way to go about it, is what my personal view would be on that. And and thank you for this. I think this is that I don't have anything else to add.
Thank you, Dr. Ashutosh. I think MCI is very, very important, and I'm glad we've taken this topic kind of not ignored, but on the back burner most of the time. And persons normally overlook it as normal aging. So I think the earlier we do, the better it is. And as you said, it takes anything from 5 to 15 years for the symptoms to actually show up. So it's better forearmed and forewarned to refrain from getting diagnosed eventually with dementia. So thank you once again, and we look forward to the discussion that follows. So now we come to the second part of the session, in which we have Jwala Narayanan, the lead neurologist, neuropsychologist, and who is very, very experienced in her field. She has special interest in bilingualism, memory, dementia, neuropsychological rehabilitation. She runs a community enrichment program to manage dementia called CogWorks. She's worked at the grant from Burning Man, US, for a community project to promote healthy aging and to manage dementia also. She's received the International Neuropsychology Fellowship Award from the British Psychological Society and Division of Neuropsychology UK. Welcome, Jwala. Look forward to hearing your perspective on what the theme of the session is. Welcome.
Thank you. And thank you for the kind invitation and the introduction. Am I audible?
Yes, yes, you are. Thank
I'm
you.
going to share my screen. So are you able to see my slides? Yeah. Yes. So no, sorry. Are you able to see my slides? Yes. Okay, great. Okay, so I think we've had lovely introductions by Dr. Puranik and Dr. Ashutosh. So I'm not going to go into too much details about MCI per se. I'm going to talk a little more about what we do in neuropsych and trying to diagnose MCI and our challenges. So just to briefly sort of just reiterate what they said, that MCI as a syndrome refers to cognitive impairment that does not meet criteria for dementia, but is more than normal aging. And as we've discussed, that there are many criteria, but they all do overlap at some level. And in general, the criteria includes a measurable deficit in cognition in at least one domain in the absence of dementia or impairment in everyday functioning. So this is a nice flow chart. Of course, it's not exhaustive. And I think now we have so many more different types of MCIs. But I think largely, if we look back at where MCI began, and the main distinction is whether there is memory impairment or not. Because if it is memory impairment, then we're thinking more on lines of Alzheimer's related dementia. And it could be Alzheimer's or a mixed dementia with vascular dementia as well. And if there's no memory impairment, then we're looking at all the other kind of dementias, including the primary progressive aphasias and the movement disorders. So as neuropsychologists, what are our challenges? So one is the changes that we see at an MCI level is very, very subtle. And, that's the hardest part, right? We're trying to see if this is just normal aging or is this something that's more organic? And I think as psychologists, we need lots of tools to pick up cognitive problems, and we don't always have cultural appropriate tests. So a lot of the tests that we have just been adapted, and sometimes we're not sure if it's really picking up what we're looking at. We don't have enough normative data. So India is very diverse, and we have more than 27 official languages, and we have many different cultural backgrounds. So sometimes using normative data from here for someone coming in from West Bengal or another part of the country is not very relevant. And also our education backgrounds are so different. We have different education levels, so we don't have enough normative data. And for MCI, when we're trying to pick up something so subtle, it's really important to be able to compare that individual with their background, their people at their age, their social strata, to see if this is really something that's organic or just a result of cultural differences. And when things like depression and mood-related factors can, present like a pseudodementia, as Dr. Ashutosh also mentioned. So what do we do to sort of overcome these challenges? And one is, I think, with regards to changes that are subtle, I spend a lot of time in taking a very detailed history. And I think that plays a very, very important role. So the tests are important, but the history, I would say, is equally important, if not more. Especially when you have people coming from different cultural backgrounds, it's the history that's really going to give you a lot more details than what your test might, because someone might just fail at everything or do well at everything, but you're not able to pick up those subtle changes. So look for things like what were they doing? What was it that is concerning to the family? What has changed? What have they stopped doing? And also it helps to sort of go back in time to see when did they stop doing something. So if the family says, oh, they're not cooking anymore, but then have they been cooking for the last 10 years or have they had a maid, So things like that. So it's really important to go back and play a little detective and sort of go into the deeper history and find out where the things have changed and where things have happened. And also, I think when you're reporting this, it's very important. I think if there are any psychologists here, when we're reporting this for the neurologist, because I know I work very closely with Dr. Ratnavali as well. And these are things that they're looking for. So it's really important to put these things down in your reports as well, rather than just putting scores. So we don't have a huge battery of tests, but we do have a few tests now that seem to work quite well. And I'll go into some of those tests in a bit. But we do have like some tests in Linneman's battery that work quite well. The ICMR battery that is now going to be, available to many people. We do have it in 5 languages. We will have some, better norms at some level. So I think we do have tests, and I think in the north there is a lot of tests from PGI that can be used. So we do have some tests that work quite well. I would say liaise with people, talk to people who have been working in the area to try and understand what they use, speak to different neurologists, and do get the appropriate tests, because we do have tests now that work to some extent. And with regards to normative data, like I said, that's also coming up. We are having more studies that are taking place. So we are having more normative data. It's really important to look at literature, because I think a lot of papers are being published, and that will give you some normative data as well. And, when I started practice, I just didn't have normative data, so we just collected our own data. So if you have a bit of research interest and you have some resources, it's really quite helpful to just collect your own control data for some of the tests, especially for the older population. So people above 70, there's very little normative data for that age group, so it might just be helpful to collect your own data. And so depression can be quite, a pivotal sort of role in making something look like a dementia or MCI versus normal. So if there is depression, it's very important to treat the depression and call them back, because you will see a change. So I think treating the depression, of course, with medication, but also things like talking to the family, asking them to intervene. Some counseling can also help. So these are things that we should look out for to help us work through the diagnosis. So with regards to the tests, for memory, what we find is quite helpful is episodic memory, as Dr. Ashutosh also mentioned. So the list learning, figure recall, not the Ray complex figure. I use another one. I use the R-bands, which is much simpler. So that's a simple figure recall test, can be quite helpful. I also use a visual association test, which is quite helpful. It's basically pairs of pictures, and then you show them only one picture, and they have to recall the picture that came with that. And that's quite sensitive in sort of differentiating MCI from AD. From Alzheimer's. And I think if you're really looking at memory, the important part that you should look at is recognition. So Alzheimer's, when they are not able to remember something, they can't recall something, you will also see that they don't always do well on the recognition component of the test. Whereas in MCI, they tend to do a little better. So if you see someone who's not doing so well on the recognition, but still able to remember certain things, and that there's something going on. So that's quite important. And also with regards to recall, when you have a 0 recall and you have good recognition, that might kind of fall into MCI also. Semantic fluency. So reduced semantic fluency, again, is indicative of, memory, amnestic kind of MCI. So that's something to look out for. With regard to language, we sort of have a modified naming test that we use, but now part of the ICMR battery, there is a picture naming test that can also be used. And it's quite important to look at other aspects of language. So I think if you're familiar with the Addenbrook's cognitive examination, that's the ACE-3, they do, there's a fair amount of language in that. And I think that's quite helpful in sort of picking up any language related issues. So that should be enough. Otherwise, we'll just send them to Sonal. And with regards to visuospatial tests and visual construction, there is a line orientation, which is quite helpful and quite sensitive to, again, Alzheimer's. So if you're looking for that, the line orientation is quite helpful. And a simple figure copy would give you some information on visual construction. And executive function is something that we don't have great tools of, and also because executive function is so distributed, right? You have reasoning, problem solving, decision making. But I think largely these tests, like the letter fluency, digit span backwards specifically, trail making test B, and the Brixton spatial anticipation test are quite nice and work quite well with, these are all urban population that I'm talking about. So these tests seem to work quite well with them. And for the attention, a coding task, I haven't added it here, but a coding task is quite helpful. You'll also get an estimate on speed, and digit span forward and trail making A is quite helpful. So these are tests that you should find helpful. So just to give you in context, very briefly, so MCI, that might be AD related. What we're looking at is memory impairment on memory tests. Look out for recognition, as I already said, and memory changes in clinical history. So what kind of changes are they saying? Are they just saying that they're forgetting, their phone here or something there? Are they losing their way? Are they forgetting to turn off the gas and doing the more important memory related tasks? That is quite clinical. And then in terms of vascular related MCI, what we're looking at more is in terms of speed of processing, digit span backwards, trail B, they'll fail on, and other tests of executive functioning, they might not do so well. And again, a lot of this is sort of tied to the working memory deficits. So they might be able to reason, or they might be able to make decisions, but it's just that working memory that pulls their performance on the other tests. Also look out for changes in mood and motor symptoms. That's when we're thinking more of vascular. And other kind of MCIs, you just have changes only in language or visual construction or praxis, or executive functioning, and that's when we're looking at something that's probably not AD related. Okay, so I have a couple more slides on management, and maybe we could come back to that later. So thank you.
Thank you, Jwala. It so happens that time is never enough. And, I think what we should do is, I'd like to hear all the speakers and not rush through. So maybe invite the next panelists. Thank you, Jwala. And hopefully we'll have time to squeeze in for some more slides. I think Dr. Chavan also had some slides, right? So let's see, but we'll go on to the next panelist, please. Welcome, Dr. Archana. Look forward to hearing you too. She has a master's in neurophysiotherapy from GS Medical. She's a director team physiotherapy services in 2007, neurophysiotherapy consultant at Dinanand Mukesh Hospital since 2013, worked with dementia home Tapas for 2 years in Pune, and she set up the physiotherapy department there, and she's engaged in caregiver training, and she's also spreading awareness regarding dementia, which is so very important today with rising numbers of population getting dementia. She's also been working with other neurological cases, like with special interest in stroke and vestibular rehab, and involved with the support group also. And she's an active volunteer in neuro rehab at the IFNR. So welcome, Dr. Archana, and we look forward to hearing you.
Thank you, ma'am. Thank you for the introduction. I hope I'm audible. I'll just share my screen. Can you see the slides? Sonal?
Yes, ma'am. We can see the slide.
Yes. Okay, thank you. So after listening to the neurologists and the neuropsychologists, neuropsychiatrists, I think physiotherapy is something where it is needed in all age groups, especially the elderly. But when we talk of dementia, there is little difference in how we go about with treating these patients. Uh, as I was listening to everyone, there was hardly anyone who said that okay, their physical ability also goes down, and yes, the age in as the people start aging, physically they become weak. But in people with dementia or minimal cognitive abilities, their weakness is a little more than what we expect in normal aging. So they, because they are often understimulated and under engaged in their life, because of the psychological problems, of course. So then it is a challenge that what or how much to do with these patients, and do we really push them? Do we really want them to move, or just let them be? If they move, are they going to create some problem for themselves and the family members? All these questions arise when such patients come to us for exercises of physiotherapy. But as we all know, any lack of exercises with underlying disorders definitely increases the risk of developing dementia and mild cognitive impairment. So what is the aim of rehabilitation or neurorehabilitation? The main aim of neurorehab in our patients is to restore their activities of daily living, to restore their motor function. Uh, as we all know, it's not new, and I need not tell you all, as the dementia progresses, patients start forgetting how to walk, they start forgetting how to use their hand, and they start forgetting their small motor activities, which we feel is because of their weakness. But it is not because of the weakness, it is because of the cognitive impairment. So our main role here would be to maximize their functional independence and minimize the long-term disability, which will be a difficult task for the patients as well as their caregivers. And so we all aim basically to increase function with proper equipment and definitely safety in their activities of daily living, train patients, families, and caregivers, and symptom reduction. Symptom reduction is, these are normal aging symptoms which all our dementia patients also go through, like knee pain, back pain, or fatigue, weakness. So these symptom reduction is something which we can definitely help them through. uh, we as physical therapists are teachers of movement skill, and so we make the patient learn or relearn the functional movement. I always tell my patient, if you forget something, it is like you're deleting the movement memory from your brain, and so if you keep on practicing it, it is going to come back. So especially for MCI or dementia, we do something known as rote learning. So keep on doing the activity again and again, how to do a sit to stand from a chair, how to use your walker to walk, or how to save yourself from a fall. If we keep on practicing these things, we are definitely going to help them move better. This is a slide which I really wanted us to understand, because we all feel that, okay, physiotherapy is something, we come, we ask them to exercise, we move their arms, we move their limbs, we make them walk. But it is not something which is limited to the muscles, because when we treat a patient with disabilities or a normal patient also to increase strength, this is something which keeps on happening at different levels. There is something known as sensory feedback. If you are asking a patient to move his or her upper limb or move their leg, there is a sensory feedback going on to the motor units. The muscle gets activated and the whole loop up to the brain gets activated. So basically, whenever we are training a patient, we should definitely see that it is not just a passive thing which is going on, or just not something which the patient is not understanding, but a small, even a small amount of exercise which will stimulate the brain. Maybe the patient understands the movement, the patient relearns the movement and remembers it as a task to be done. So what can we do, or what can you do? Basically, it is to understand the condition of the patient. Everyone is different with different requirements. Definitely create awareness. Do not over pamper. At least in Indian scenario, we know that there are so many well-wishers, so many relatives who keep on pampering their parents or their relatives and say, okay, if you can't walk, I am there to help you. We can go into a wheelchair. If you can't brush, I will brush for you. Presently, I'm having a case of MCI where the husband is around 80. The wife is a patient who is 75, but the husband does everything from brushing in the morning to sleeping in the night. And then I keep on wondering, ki, what will happen to the lady if the husband becomes a patient or the husband is no more? So then I tried to counsel the husband that, see, if you have to make them independent, at least in some or the other manner in few areas. And that counseling is very, very important, which is definitely done by our psychologists. Do not over expect nothing at all. You cannot expect them to get back to function, to near normal function, but you can expect them to at least come to a level where they will move by themselves or do their basic activities of daily living. Plan for short and functional goals. If we ask the patient, okay, what is your goal for this particular individual? Patients don't understand. They will give us a big goal, as if the she should understand, or the patient should behave properly, she should answer properly, or she should start walking by herself without losing balance. These are big goals which may be achievable, but after a long period of rehabilitation, and not only physical, but many rehabilitation, mental rehabilitation, psychological rehabilitation together. So we have to make the patient understand that you have to plan for short and functional goals. Repetition, yes, repetition is the key in these kind of patients. And reward, yes, these are like small babies. I always tell my patients that age above 70 and age below 5 are similar kind of brains. So if you reward them, they get more motivated, they try to do more. And patience. Patience is something which I think every one of us here, faculty, we know more about patience than anyone else. So these are little things, if we keep in mind, we can definitely get our patients do a little more than what they are doing right now. These were a few studies. There are a lot of studies of physical therapy helping in MCI or dementia. But whatever studies I've gone through, no one directly correlates physical exercise with cognitive impairment. But there's one point I would like to make is, even if there is no cognitive impairment, at least physically the patient is going to stay near normal. At least physically the caregivers may have less load, and they may be able to cater for the patient. But again, what kind of physical exercise is very, very important. And looking at so many studies, and with my experience, I can definitely tell you that it's not only one form of exercise. It's not only walking or just cycling or just moving around, but it's definitely strength training, functional training, and aerobic training, all these few different kinds of exercises together, which is going to help our patients. There is definite incidence of falls in our demented patients, as well as balance and gait disorders are definitely documented, very well documented, and we definitely see all these kinds of patients. So for these problems, we have to understand that we have to first make the caregiver aware. Maybe we are not able to make the patient aware what the problem is, but at least the caregiver, the relatives aware that these patients need walker to walk. Even if you can see that you can hold their hand and make them walk, but it's always better for them to have a walker or a supportive device which will help them in balancing. So all these aspects are so very important for physical development or physical maintenance of these patients. These kind of patients, I always say, come in maintenance category. If you keep on maintaining them, they will not progress to higher problems, but they may remain there for a longer time. Yeah, that's it. I thought Sonal had told me around 5 to 6 slides, and this is what I could share. But I would definitely love questions related to my topic, and I will be very interested in answering them. Thank you.
Thank you so much, ma'am. It was great, crisp talk. I'm sure that all of the audience have got some good points, that mild cognitive impairment is not just that we have to see only in the thinking, reasoning, memory, but also the gait and the sluggishness and the dysexecutive function and the slow movements could be very importantly to be detected. And I feel in Indian scenario, after the 60, 65, people think that, okay, they're old.
Yes,
And
yes.
neurophysiotherapy is very important, along with neuro-occupational therapy, which we need to really understand that the resilience power would be strengthened once we try to get the early identification, early rehab, moment it is milder. So
Yeah,
may I
I
welcome
think
our
just
next
just
speaker?
a second, Sonal, I would like to comment here that this should create an awareness amongst the medical professionals also, that even if it is a small, it's an MCI or the patient is still functionally okay according to the relatives, but they should be referred and they should go and undergo some form of exercise. Maybe they need not come to a physiotherapist daily, but they should definitely be involved in some form of exercise, which is very important. Thank you.
Thank you so much, ma'am. We're running short of time. We already have actually finished the time we have dedicated to session, but I'm sure it is very enlightening and audience would like to stay with us. We would try to wind up a bit early. I'm sorry, panelists. Could I have next speaker, please? Professor Gomez? Yeah. May I have Vidya ma'am introduce Professor Odette Gomez?
Yes, it's my privilege to introduce her. Dr. Odette Gomes is the former professor and head of OT at Nair Medical. Her area of interest is varied, a mental health professional with adult neurology, geri care, palliative care, wellness, very committed to these causes. And she's on the several core committees of the state of Maharashtra state government. She continues to mentor people, students who are doing their research. She's on the special interest group for people with Parkinson's disease and offers her voluntary services anytime. So that's her hallmark. And she's currently a consultant occupational therapist at the Romilla Palliative Care Center, Bandra. Welcome, Dr. Odette, and pleasure having you.
Thank you, ma'am. Okay. I know we are running short of time. Am I audible and is everything visible? Okay. So what are
Yes,
the
ma'am.
challenges?
Please go ahead.
Yes, thank you for having me on this illustrious panel. I know Vidya madam doesn't take no for an answer, and she managed to convince me quite strongly that I need to be here. But I'm happy to be here because I've learned so much. And yes, this is an area of interest for a couple of us working in this field. So what are the challenges that we face in clinical practice? The first thing that we have seen is, do we get a reference timely at the early stage? Yes, when you have diagnosed somebody with an MCI or you know that they are in the early stages of any dementia, do send a reference, a timely reference, so that they can be seen to and given therapy earlier. We in OT have run many screening camps and awareness programs so that people know that there is such a thing, know that there is some sort of intervention besides medicines. There is a non-pharmacological intervention called cognitive stimulation, amongst other things, which the OTs do. And then there is a lot of counseling that also can go through, not only for the patient, but also for the family. It is not a stigma to have dementia. And if you can catch it at the earlier stages, you can undergo all these interventions, which is cognitive stimulation for the patient, and a whole lot of intervention for training for the caregivers. Because the main focus of OT is to live life to its fullest by adapting the environment. And we train and we try to make it dementia-friendly environment for the family. And we focus on what they can do to maximize engagement in activity. So they can do whatever they can by themselves for as long as they can. Their activities of daily living, which is the USP of OT, whether it's your basic activity, whether it's walking, whether it's dressing, taking care of yourself, bathing, eating, swallowing, you need to be functionally independent. All this is with safety and ultimately enhancing your quality of life. What are the challenges we have faced in assessments? Just like Jwala says, yes, they come. When I used to work at a general hospital, you would see patients who are not educated. So how can you even test them on a formal test? But yes, we do as OTs, we spend a lot of time with them. So there's a lot of subjective assessment. Then in history taking, in talking, we have objective history, subjective history. We do non-verbal, watch them with non-verbal communications. We use projective techniques because we are psychiatry trained. All these activities, we do activity analysis. All this gives us a big feedback as to what is going on with the person. Do they have a memory issue, or do they have something like a depression which is underlying? So some of the scales that we use for quick screening is MMSE. Yes, we do get it in various languages, which is helpful. MOCA is one of the things that is relatively used. If you're doing a research and all, then you use ARDSI, and of course you use the quality of life AD. So then you get exactly which areas are affected. We have to take this into consideration. Do they have a hearing problem? Do they have vision problems? Because hearing impairment is invisible handicap. Nobody realizes it. And so whatever information, whatever sensory input that goes in, for them to have a memory gets affected because it's not really going in. So there is no input. And how will that process into a memory? So you have to check for hearing impairment, have to advise the family as to how to get them involved in the social situations within the home so that they are not left out and isolated. Vision is another problem. With this, I am also going to tell Dr. Surya and Vidya Madam, yes, we have spoken about getting them involved in technology. They need to learn minimum technology so that they are connected with people of their age, with WhatsApp. They are connected with families who are not there. There are so many apps available now. Vidya Madam has given us another app for the seniors within our country, if they are living on their own, that they can make use of. So the bottom line is they stay connected, which is absolutely of essence. They stay connected, don't go into a shell, don't go into a depression. If they come to you in a mild stage and you have to do assessments when they are in the mid stage, usually there is some sort of behavior issues, there is outbursts, it's difficult for them to sit in one place. It's difficult for some people to accept that they have a dementia or a memory issue because they may have held.
Excuse me, Dr. Odette.
Yes.
Your screen is not visible.
Oh, really?
No. So do you mind, please? And you can, since you've spoken, there's
it says screen sharing is paused. Yeah. Okay, I'll stop and start it again.
Please.
Did
You
you
can
see
go
the
through and
walkthrough?
we can reflect on what you've said, but we see the visuals at least.
Oh, okay. Sorry, I'll do it again.
Thank you.
Which one did you not see, or which one did you see?
Not at all.
Nothing? Oh.
Yeah. Thank you.
Now, is it visible now?
No, we can see you.
Oh, okay. Okay, I'll try it again. Just give me a minute.
Yes.
Not yet.
It's still saying it is paused. I don't understand why it's paused.
No.
Okay. I know you don't have much time. Even now you're not seeing, right?
No, we can see you, but not the screen.
Okay. Anyway, then you just leave it for now.
Yeah.
Because we really are running short of time, no? It's
Yes.
a pity. It's a shame. Never mind.
Yeah.
We're still not able to see, no? So it's okay. Okay. Now?
Yes.
Oh.
Merry Christmas.
Happy New Year.
Yes.
Okay. I had been through all this, so this was the initial, this was the part that I had reached, I think, no? Yes. So the assessments and why you need to take care of this. And what are the challenges faced in intervention? Intervention is a long term. No, it's long. It's not something that gets over in a month or two. So people tend to get a little tired. The family tends to get a little tired. But OT has helped. There is evidence that shows that it enhances individual sense of enjoyment and identity. They still are able to maintain their identity and enjoy within the family their everyday life. And it increases their functional independence. Unwanted behaviors are decreased, and most important, it lessens the burden of care. Yes, we need a caregiver all the time, but we can lessen the burden of care. Financial is another issue which is a challenge faced by the caregiver. So what we as OTs can do to solve this? There is caregiver burnout. So we have caregiver supports. We give them a toolbox which has all these strategies that they can use, compensatory strategies for the patient, for the caregiver. We empower them with the information. They have understood what is short-term memory and what is long-term memory. They don't need to know more than that. So then they know that when the person is talking about something that happened long ago, it is still long-term memory, and what is affected now is short-term. Ergonomic changes to make it dementia-friendly environment, and tips and tools are given to the caregivers so that they can be helped. Yes, cognitive stimulation helps with people. There is evidence shown. But one thing that we need to keep in mind is elder abuse, especially when there is a hired help to take care of these people, because we don't understand the patient, the client doesn't understand how to express what is happening, but you need to pick up these subtle non-verbal communications that they give. They get a little agitated when that helper is there or something like that, or refusing to do certain things with the helper. There are chances of elder abuse, so that's something that we need to take care of. But by and large, these are the challenges that the OTs face. Yes, we are happy that the doctors are also going to refer at the earlier stages for non-pharmacological interventions, which will help them. Our friends, the physiotherapist and the psychologist also will do intensive testing so that we know exactly in which area and which domains are affected. And then our speech therapy friends will help if there is swallowing issues. Thank you.
Thank you, Odette. Wonderful presentation. It's getting so exciting and interesting that Father Time doesn't help us anyways. So we'll have the last speaker. Sonal has been at it since the thought was put in her mind. I just suggested, I said, Sonal, how about having a session? And she jumped at it and I was delighted. So we have Sonal, who is well known to most of us. Sonal Chitnis is the assistant professor in SLP at the Pune University, and she's a coordinator memory clinic at SASLP, where she is an assistant professional. She is affiliated to the Bharati Vidyapit University Medical College, School of Audiology and Speech Language Pathology in Pune. consultant speech pathologist at Neurology Department, Dinanath Mangeshkar Super Speciality Charity Hospital, total experience of 15 years. I'm sorry I'm talking fast because I want you to know how important our panel is and how much experience they have. Aphysiology and cognitive neuroscience, neurorehab, stroke, epilepsy, dementia, MCI, right up to advocacy and education. Member of IFNR, ISHA, EAN, WFNR, NFOSD, and NSPI Pune. Her major achievements have been she's been a Young Investigator Award winner at the World Stroke Congress. In 2016, she's received the Sant Kavi Surdas Award in 2015 with an EAN travel grant for attending a training session on brain dissection and application of language and cognition at Wisconsin in 2016, a volunteer and advisor of Aphasia and Stroke Association of India, and volunteer at the Epilepsy Foundation India, expert group Aphasia, EAN member, Neurorehab subsection and IFNR, coordinator SIG, Clinical Aphasiology, Indian Speech and Hearing Association, ISHA, and she's been invited for 37 lectures. She's had 8 publications and presentations numbering 31 in national and also other conferences. She's been presenting her experience. So Sonal, can we have you on the SLP, please? Thank you.
So I would like to thank Ms. Vidya ma'am and Dr. Nirmal Surya sir, IN Neuro Rehab section, and all my friends who are into neuro rehabilitation of MCI, dementia, cognitive communication rehabilitation. I'm really delighted to be here today as part of the panel and among you all here. Without taking your more time, I would like to give a very short put forward my perspective on mild cognitive impairment. As a speech language pathologist in Indian scenario, when I specialize in neurocognitive and communication disorder, I feel there is so much to know about language we speak, understanding of attention, memory, the thought processes, the executive functions, and mild cognitive impairment. It's just mild, but how mild is mild? In my perspective, as a role of speech language pathologist, it's very unclear, not well understood. They're very poor understanding, and that's how many people have not taken up neurocognitive communication disorder, because we lack training and involvement from the specialized care of interdisciplinary team members here. So knowing the brain behavior is very important for a speech pathologist like me who specializes in cognition. So when we understand, when we assess the small children or adolescents or young adult or an elderly with any acquired brain injury, so what happens that when we speak, when we connect our thoughts and we communicate, it's very importantly that many times we don't take into consideration how important is having our memories. So it's important that we consider thought process and then mild cognitive impairment in terms of occupation. So how mild is mild for a farmer? How mild is mild for a teacher? How mild is mild for an CEO of a company? Or it's important for a veteran or a retired person. So it's important that we need to have a standardized tools. Many times we get to see people with Alzheimer's dementia, vascular dementia, who are coming to us with good cognitive reserve, that though they score somewhere relatively average on the tools we do, per se MMSC is not a great tool for MCI. So we need to have a MOCA, mini ACE, some good tools which Jwala ma'am has referred. However, it's important to understand the quality of life he or she was spending earlier, the active social life, and then what are the exact point of change in her behavior, in her attention, in her memory, in her communicative abilities, in her occupation, everyday independence, and how it is affected. So that is a challenge which we face in common picture, that people are not referred, people don't come till they get frank symptoms. And in terms of intervention, we need to have early intervention so that we build a good neural resilience with art, with music, with memory cognitive tools available, having an active life. Working on depression, mental health is very important because that is a precipitation where someone can actually have a long-standing depression, pushing him or her towards the cognitive impairment, towards Alzheimer's, towards a vascular pathology. The diet, poor exercise, poor social health is very important. And that's how I feel we need to really work on identification of cognitive impairment, helping the person who really requires to live a graceful, healthy life, who has given his life to his children, society, for making a better living. So every elderly needs to really work on, is it a mild cognitive impairment? Is it age associated? Is it somewhere hindering his quality of life? What he should do is to get a good psychologist, OT, PT, and speech language pathologist, rehab help, as well as good diet, pharmacological help if they have to be required to give attention for their memory, and the neuropharmacological help for the processes which are pathology like FTD, frontotemporal dementia, vascular dementia, the diabetes, and the other metabolic aspects, and the systemic diseases requires good pharmacological help. Also, if there is a early motor neuron disease or early Alzheimer's, depression, multiple system atrophy, many times I feel in a rural population they are not well identified. So we need to really understand that it's a teamwork, it's not just one person's work. So GPs, BMS, BHMS, we have many alternative medicine people.
I think Sonal has a bad network that she's just messaged. So I think as it is, we've run out of time. So we'll just close this session, but not without reminding you that this is the beginning of the many that are going to come. And oh, here she's back. So Sonal, would you like to continue?
Yeah, so with that, I would my talk that to identify the cognitive impairment, are they age associated or early precursors with good cognitive reserve or very poor cognitive reserve? And how do we help the person with MCI somewhere prolong or delay developing frank dementia with a good cognitive resilience, neural resilience, with the family support, with the caregivers help, and give him a dignified, good life, what he or she deserves. So it's important that we all work together, so reducing the risk of dementia. Thank you so much.
I just want to get back to say thank you very much. Exciting session. First of the many to, I think it's very prospective, very informative. I've been getting messages saying that it's been a great session. Continue. So I'm just kind of subtly warning that we're going to meet again and again and again. Okay. So as Odette said, that I don't take no for an answer, please bear in mind, and I'll be at it. Good luck, God bless, and I think we will take it up further. Thanks a lot, and making it a great, great session, very holistic and informative in every aspect, neurology, physiotherapy, speech, occupational, neuropsychiatry, neuropsychology, what have you. And I'm delighted as being at the Secretary General of ARDSI to know that we've got such a fantastic multidisciplinary team that we can fall back on, and we look forward to working together. Thank you very much.
Thank you. Bye.
Sorry, all of you, from my side, the tech errors and the time management. I think we should have one exclusive session for management of MCI and the challenges and what could be suggestions from all the panelists here. And I really request all of you to join back with us. And I want to thank the chair, Professor Midhirata. I would like to thank Nirmal Surya sir. Do I have Abhishek sir here?
No, he
And
couldn't
Professor
join
Pauranik sir. Yes, thank you so much, Dr. Odette. Professor Chauhan, you were fantastic in putting forward in nutshell the MCI and the neuropsychiatric perspective, the recent imaging and the recent diagnostic and therapeutic intervention. I thank Ms. Jwala Narayanan, wonderful neuropsychologist in India, and I really request her that we would look forward listening to your some sessions only on the MCIs, which would be very enlightening for the audience here. I thank all the audience and IFNR, Indian Speech and Hearing Association, Indian Academy of Neuro Rehabilitation, Neurology and Neuro Rehabilitation subsection. Thank you so much all. And last and not the least, my thanks to Vidya ma'am for the ARDSI to do the wonderful work for the elderly and dementia. Thank you so much, ma'am.
Thank you, Sonal. And that is the second last bit, because the last bit is thank you, Sonal, period.
Bye. Bye.
Yeah, bye-bye.
Thank you. Bye.